everyone, this is Ada from MPPA Learning TV. This video is titled Quick Facts on Hemorrhoids and Anal Fissures. This video comprises a quick review on hemorrhoid and anal fissures. Resources used for the video includes NCBI articles, medicine texts such as Goldman, Cecil, Harrison's, and pathology and medical websites. My aim for making this video is to simply make it easy for students, nurse practitioners, PAs, or any medical professional, make it easier for them to understand hemorrhoids and anal fissures. This is strictly a mini review, not a robust review of content. General principles of hemorrhoids. Hemorrhoids are termed varices or enlarged/engorged vessels, which are circumscribed to the hemorrhoidal venous reticulum or plexus or network. Etiology of hemorrhoids is multifactorial. Examples include pregnancy, straining, constipation, prolonged sitting, heavy lifting, weight loss, obesity, anal intercourse, and rectal surgery. General principles of anal fissure. Anal fissure is simply a tear that is longitudinally located to the anal canal below the dentate line. The etiology of anal fissure is not clearly understood. However, the conjecture is that trauma to the anal canal is the main culprit. Okay, some examples of etiological factors of anal fissures include the following. There is an overlap of causation with hemorrhoids. To further explain, they have similar etiology profile. There is equal incidence in men and women, and is actually more prevalent in middle-aged individuals. Fissures are classified as typical, presenting posterior, midline, or anteriorly, while atypical fissures present distal to midline and very indicative of serious pathology. Causal factors of atypical fissures include HIV, herpes, anal cancer, and inflammatory bowel disease. Okay, here we have the anatomy of hemorrhoids. Given that this is a quick review, these diagrams illustrate both the vascularity or the vascular nature of the rectal vault and, on your right, the hemorrhoidal plexus or the venous structure of the rectum. So the diagram on your left illustrates the vascular structures in the rectal vault, while the diagram on your right shows you the hemorrhoidal plexus. Okay, as previously stated, the previous diagrams illustrate both the vascularity or the vascular nature of the rectal vault and the hemorrhoidal plexus. Additionally, this diagram here shows the dentate line, which is an extremely important landmark given that this is the point of intersection for vascular and nervous structures. Anatomy of hemorrhoids. Okay, the diagram on your right illustrates the difference between normal physiology or anatomy of the rectal vault versus hemorrhoidal anatomy. So when you look at this image before you, the normal anatomy doesn't have any protrusion. There's no enlargement or protrusion or hypertrophy in the rectal canal, while in the diagram below there is a hemorrhoid, in the rectal canal. So this just kind of gives you a basic overview of what the normal physiology is and what it looks like when there's a hemorrhoid there. The pathophysiology of hemorrhoids consists these mechanisms: increased intra-abdominal pressure, deterioration of the anal cushions with venous dilatation resulting in hemorrhoidal engorgement. So these factors lead to the hemorrhoid that you see visible here. Grades of hemorrhoid. So here on your right is a couple of images that show the different grades of hemorrhoid. What I'm going to do here, I'm just going to organically just explain the visuals, but not go into like the physiology or the anatomy of it. So in grade 1, you can kind of see that there is a protrusion on the above the dentate line. That's grade 1. Grade 2, there's a protrusion that is gradually getting under towards the dentate line and almost getting below it. Grade 3 is fully below the dentate line. Grade 4 is externally protruding. Classification of internal hemorrhoids. Here we have more visual of hemorrhoids. I personally am a visual learner, and I love to look at diagrams and pictures, and I feel like it gives you a more rounded knowledge. So this diagram is showing both gross and surface anatomy of internal hemorrhoids. So the grade 1, it has the anatomy part on top and I would say the gross anatomy at the bottom. So basically it's protruding out of the canal but does not prolapse completely. There is also a chance of bleeding. There's also a chance of bleeding with all the other grades, but it may protrude without bleeding. Grade 2, you can see the physiology, the alteration of physiology on top, and at the bottom shows you what it looks like on the, on the actual patient. So the hemorrhoid bulges out of the canal while straining during bowel movement and can spontaneously return back to the rectal vault. Grade 3, this is what it looks like anatomically, and below is what it looks like on the surface. So here the hemorrhoid may protrude from the anal canal without straining and requires the patient to manually manipulate it. Grade 4 is complete prolapse, and just as you can see on the above, a complete alteration of the rectal canal. And you can below you can see that the hemorrhoid is incarcerated, and protruding, and is irreducible. Anatomy of anal fissures. It has been proposed that hypotonia meaning rigidity, stiffness of muscular structures of the anal sphincter, precipitating from trauma or other factors, leads to the singular tear notable in anal fissures pathology. So this is a singular tear, and this is a classical presentation of anal fissure. This diagram here also again illustrates the classical presentation of an anal fissure via anoscopy. Here is the fissure. The diagram just illustrates the difference between anal fissure and hemorrhoids. Here is a fissure, and here are the hemorrhoids. Here we're going to go over the key facts on hemorrhoids and anal fissures. Key concepts with clinical features of hemorrhoids include the following. External hemorrhoids is visible. Symptoms include perianal pain, perianal mass, difficulty with defecation. Other features include difficulty sitting, standing, mucus discharge, stained undergarment, blood streaks on stool, blood drips in the toilet bowl, anal itching or pruritus, friable mucosa, and thrombosed hemorrhoid. Thrombosed hemorrhoid appearance is a deep purple, presents with intractable pain, and only surgical resection provides relief. Diagnosis of hemorrhoids include excluding colon cancer, inflammatory bowel disease, adenomatous polyposis, along with any GI alarming symptoms. Microcytic anemia via CBC and performing endoscopy. Okay, here we have more key facts on hemorrhoids and anal fissures. The treatment modalities for hemorrhoids include sitz bath, increased fluid intake, aerobic exercise, high fiber diet 20 to 30 gram, bulk laxative, stool softeners, topical corticosteroids, and glycerin suppositories. Know the grades of internal hemorrhoids. We have already discussed the alteration in physiology on internal hemorrhoids and the classifications. Grades 1 and 2 and a subset of grade 3 refractory cases of internal hemorrhoids can benefit from elastic band ligation and injection sclerotherapy, while grades 3 and 4 are treated with surgical hemorrhoidectomy if conservative treatment fails. The clinical features of anal fissures include tears in the rectal vault or wall. Pain is disproportionate to the size of the lesion or tear. Bright red staining on toilet paper. Treatment includes topical nitroglycerin and surgery for refractory cases. Make sure, extremely important, to exclude secondary diagnoses such as rectal fistula abscesses, IBD, STDs, especially syphilis, HIV or HSV, TB, colon cancer, and so forth. Treatment modality is very emblematic or similar to the first-line treatment for hemorrhoids. I truly hope that this video gives you at least a quick overview of what hemorrhoids and anal fissures are about. Thank you so much. Before we go, I just wanted to show you these two diagrams that both illustrate the process of hemorrhoidal banding or ligation. So both images, gives you a detailed, representation of what the process entails. Thank you so much. Thank you so much for watching this video. Please subscribe to our channel.